Okay. Hello, everyone. I'm glad to see all the people stay until Friday, very late at evening, which is a key of success of this meeting. So I would like to start the last sessions. We were waiting for Dr. Sohail, but I think we start the session until he come. So I would like to introduce our first speaker, Dr. Adnan Al-Khafaji from Iraq, is a director of the Cardiac Center. He will talk about distal radial approach in ACS patient, CCC patient, first Iraqi experience. I'm one of the group of starting the distal radial artery in Cylinder Club in Japan with Dr. Yoshimachi. It was from my university there in the Doka University group. And it's a nice approach to talk with Dr. Adnan, starting about distal radial.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you very much, Mr. Chairman, Dr. Khalid, and the panelists. Thank you very much, Dr. Mahmoud, for your invitation to be here. Actually, I am talking about a recent revolution in interventional cardiology, which is the distal radial approach for coronary angiography and intervention. Now, I would ask one question for us. All of us know that the guidelines prefer or recommend that the radial approach is a class 1 indication for interventional cardiology in acute coronary syndrome. Anybody agree with this or not? So, distal radial approach, second question, is a class 2A indication for interventional procedure. Anybody agree with this? Yunus, best you? Okay. So, how many radialists here from our group? Oh, good number. Okay. So it will be something interesting. So distal radial access, my story with this approach started 4 years ago when I went to Georgia for some reason, and I saw some of interventional cardiologists start and interested in doing this procedure. You know that the 3 or 4 countries in the region started or innovate the distal radial approach. Fortunately, one of them is Egypt. So Georgia, Egypt, to my knowledge, Iran, those who are first to start for distal radial approach for coronary procedures. So why distal radial access? It is a new site for cardiovascular intervention, including coronary angiography and angioplasty, with coronary stenting and intervention of even complex coronary procedure. The main advantage of this approach are less frequent radial artery occlusion. This is the point. So less frequent radial artery occlusion post-procedure and short hemostasis time with very low local vascular complications. The main disadvantage is the difficulty of the cannulation of the artery, especially in cases of the lack of expert in this access. So this is the medium-sized study. It is a Dimitri study, distal radial versus traditional radial in interventional cardiology. It was done in Iraq, Nasriya Al-Rabi' Cardiac Center. This is a private center in the south of Iraq, and majority of procedures are done through the distal radial approach. But in the last year, we decided to do some registry, and we are starting to do this. So the aim of the study is to put a highlight on the first reported cases of distal radial artery coronary angiography and especially coronary intervention in Iraq, and detect any local vascular complication and other during this access in comparison with a proximal radial approach. 180 cases of patient randomized to this study with different acute and chronic coronary syndromes was randomized to this study. It is a prospective study in 2022. I will not go in more details. So our primary end point for this study is the radial artery occlusion. So we have many different secondary endpoints, and I'm searching about some studies in the area. I found one study in one of the distinguished brothers from Palestine with his team, Dr. Yunus Darfur. Yes, it is at Darfur.
Darfur study.
Yes, Darfur study, which encouraged me also to do this registry. So, how to monitor the radial artery occlusion? Actually, we mean not the radial artery occlusion at the site of the puncture. We mean the radial artery in the forearm, and why we try to preserve this. The aim is to avoid hand ischemia or the occlusion, and we use radial artery to spare it sometimes for radial conduit, and the distal radial approach will preserve this by going or puncturing the radial artery distally in the snuff box when it gives the branch, to a superficial branch, to the superficial palmar arch. So at one month, we did an ultrasound, vascular ultrasound, for detection of the radial artery occlusion and at the discharge of the patient. We can see the rate of the number of arterial occlusion in this registry. For the distal radial, we have 3 arms in this study also. You know, we will never forget the femoral. It will add nothing, but it is really the real site for the interventional procedure. So the proximal was 2 cases, 3.3 from the 60, and the rate of the femoral artery occlusion or thrombosis was also 0. The average time from needle to sheath insertion, from the needle, the puncture, from the first puncture to the sheath insertion. So we can see for distal radial artery is 2.2 minutes, and the proximal radial is 1.3 minutes, and in the femoral artery it is less than 1 minute. Feeling of comfortability and cost effectiveness from those patients. You know that distal radial artery, the feeling of comfortability for the patient is 96%. And for a proximal radial artery is less, 93. And for femoral artery, 33%. So, local vascular complication, hematomas, compartment syndrome, dissection, limb ischemia, it was 0% for distal radial and 3% for proximal radial and 6.6 for the femoral artery approach. Time, which is important for discharging the patient, especially this is for coronary angiography, not for the primary BCI this time, is that 2.1 for distal radial and 3.4 for proximal radial and 18 hours for femoral approach. You can see the cost effectiveness, it is clear. And we have, all of us, you know, the site of the distal radial, and we have the distal, sometimes we go distal, snuff box in the mid, and in the proximal in the snuff box. Both groups, for radial, traditional radial and proximal radial, we focused on patent hemostasis. This is to show how the procedure.
To demonstrate the procedure, you can see.
So this is the first brick.
This is the gush of distal radial.
And we are using cylinder Tiroma sheath.
So, because of some manipulation is needed, okay?
And
So
mostly I'm using a 5 French sheath for the angiography, but for the intervention, 6 French sheath and even 7 French sheath.
This is a Seldinger. This is a 6 French. Please give me. Okay? Sheath. But
Anesthesia is very important, because if you don't anesthetize the patient perfectly, spasm will occur, in addition to use the cocktail. Already we know it. This is an example. We can deal even with complications of distal during distal radial approach intervention. This patient presented for chronic stable angina management and stenting of the left circumflex. Distal left circumflex was done. After the procedure, before finishing, there is something happened. The patient develops chest pain, severe chest pain, and that was the angio. What do you see? So it was yes, very good. Guide related left mainstem dissection, and we did the proper procedure, ballooning, kissing balloon, put this. Everything was done through the distal radial approach, and that was the final result. So you can deal with perforation, complication, mainstem intervention, and other imaging, and so on. So my conclusion, before that, my conclusion is that in recent American and European interventional cardiology guideline, the radial approach is a class 1 recommendation for coronary angiography and intervention. The distal radial approach is a promising technique. In this study, we established that it is visible, safe, and procedure, and that is more comfortable for both patient and operator. Especially, I am using the right radial approach in majority of the cases. I am not preferring the left radial approach, left distal radial. Okay. There is a significant reduction in the rate of radial artery occlusion when using this axis in comparison in this study registry to traditional radial. There were significant reduction in wrist hematoma. The distal radial proportional to the improvement related to the experience in this. So recommendation that it is the preferred coronary access, and all cardiologists should encourage, especially young cardiologists, to do this. And people and medical health provider must be educated through the media and health programs about the safety, efficacy, cost effectiveness of this novel type of intervention. لأنه مرات احنا خاصة بالبرايفت بنشوف الديستال راديال أو راديال يفكر إنه هي هذه كانيولا و يعني ما ينطيها قيمتها. Lastly, this is the slide. هذه الزقورة في ذي قار مدينة الناصرية اللي زارها البابا قبل سنة، وهذه الأهوار المارشز في مدينة الناصرية. And thank you very much.
Thank you, Dr. Adnan. Excellent talk. I have small questions. I don't know why until now it's the snuff box starting 2015 when we started in Tokai University and with a Japanese group, but until now is not replacing and is not spreading like a radial, even though it's, I don't know, because when the people switch, when the community start to do radial and start to convince the people switch from femoral to radial, it was really a big difference between major bleeding, especially in the acute coronary syndrome and the ACS patients, and this changed the practice outcome. But when we are talking about a very small number of distal occlusion or end radial artery occlusion with asymptomatic patients, the majority of the patient we don't know. It will change the practice to. Do you think that the snap box is coming to change the practice to from?
Okay, I will give you some interesting point from experience. So, as you mentioned, sure, when we change from femoral to the radial, there is a big difference. And the mortality has been improved, especially in acute coronary syndromes. But when you change from the proximal radial to the distal radial, and even in a disco trial, which is the largest trial till now, disco radial trial, it includes more than 130%, 1,300 patient. There is no big, it is non-inferiority trial. So it is non-inferiority trial searching about the rate of radial artery occlusion. So, but I promise you, if we are interested in the distal radial, the guideline will change later on because it is a very promising procedure. But there is no big difference till now. Yes.
Actually, to transfer from femoral to radial, there was a very big jump. And there was a very big excuse, actually, to change from very comfortable to the physician to something really changing the mortality sometimes in acute MI or something like this, and changing the side effects significantly. So the excuse of changing from femoral to radial was very, very explained, very well explained. But from radial to distal radial, actually the benefits that we are talking about, it is not that genuine, it is not that great. But the comfortability of the physician, actually when we start the distal radial, the indication for that, which you did not mention, I hope that you mention it, the comfortability when we do the procedure from the left side, because it is so difficult to do it when you do left radial and you do it this way. So all the catheters, everything is away from you. So the distal radial actually was to bring the left hand beside the right. So you keep all your equipments here. So as a physician, as practitioner, as interventionist, you have everything beside you instead of jumping of the patient, especially if you have an obese patient where you cannot do it. So the main indication actually to make everything comfortable, everything is sterile, everything beside you. Now when we come to the benefits of decreasing hematoma or the side effects or the occlusion of the radial artery, these are really minimal in comparison to shift from femoral to
شكرا جزيلا دكتور رائد الورد. راح احكي لك قصة حقيقة. طبعا احنا اساتذه قصه قصيره كلش. يعني طلاب كليه الطب من يجي يشوف يفحص الطالب ما يلقى راديال بلس عنده، هذا ما عنده، وياخذ الهيستوري. rate of the radial artery occlusion is important. That's why we are searching for distal radial. When you turn to the left, from my experience, you make the brachial artery and axilla tortuous, and we face some difficulty. This is for yes. Okay.
We have a lot of questions. We may end the question until the last speaker, and then we continue because it's a lot of discussion. I know it's a very interesting topic. So we move to the next one. It's okay.
First of all, I want to appreciate you for, to my knowledge, you may be one of only few doctors who are practicing this method of coronary angio. But during this data, you hadn't tell us how frequent frequently you face failure of puncturing the artery distal.
Yes, because there is a secondary end point about the spasm, failure. It was less than 10%. Less than 10%.
خلينا نحكي على الراندومايز ستدي. الراندومايز ستدي تبعتنا كانت السكسسفول ريت اوف فانكشنينج.
انا اريد اسمع منك، يهمني كل شوي.
98%، يعني حتى الديستال راديال. الديستال راديال كانت حتى في ديسكو ستدي، والستدي تبعتنا الاوكلوجن عشان جميع الاوكلوجن ريت اولموست زيرو. في الديسكو ستادي 2 كانوا عندنا زيرو، عندك نفس الشيء زيرو. فالبينفيت للديستال راديال موجود. المشكله في الديستال راديال ان ليرنينج كيف بتحتاج ليرنينج كيف نفس الشيء اللي كان زمان في الفيمورال. احنا كنا في المانيا غصبونا ان نساوي راديال عشان نغير من فيمورال لراديال، فبحتاج وقت عشان نغير. بس بعتقد لازم يفهموا او نفهم احنا جميعنا ان الديستال راديال ممكن تكون هي البريفيرد اكسس في المستقبل، ولان في بينفيت هيموستاسيس تايم اقل، ستي ان هوسبيتال اقل، الاوكلوجن اقل. حتى في ناس مثلا عندهم اند ستيج رينال ديزيز ممكن يستفيدوا من الديستال راديال ابروش. وانا بهنيك على الستادي تبعتك، وبتمنى انكم تكملوا اخرى.
خالد حتى انهي، وبعد ما ارجع، بعد ما اريد هذه حتى انهي بكلمه واحده.
بعدين بس شغله
عاشت ايدك يونس.
ultrasound guided functioning
So because
is very important.
now we will not finish. We'll not finish.
Okay.
So the distal radial is, we know it's great, and we have a lot of indications, especially the people would need to use the radial for graft. So we next speaker, Dr. Islam Abu Saada. Abu Sido.
Good evening, everybody. I know it's the end of the day, everybody's exhausted. So I would like to share with you one of probably an interesting patients. So my patient is a 43-year-old gentleman who's known to have hypertension, dyslipidemia, who's known to have a strong family history of coronary artery disease. He had an ischemic heart disease and underwent stenting 3 years ago. Presented to the casualty with progressive chest pain for the past 5 days. This chest pain was radiating and active to the left shoulder. So he had no surgical history, no non-drug allergies, and active medicine were aspirin, Plavix, rosuvastatin, beta blocker, isosorbide, and PPI with a blood pressure pill. He had a strong family history of premature atherosclerosis, but apparently the patient is a smoker and active smoker with a 90-pack a year smoking. So basic workup were done in the emergency. I have probably an EKG that demonstrated some inferior changes. I'm sorry, because of the poor quality, I didn't put it. Patient blood work completely normal apart from mildly elevated troponins, despite a CPK and CKMB were negative. So I'd like to share with you probably the interesting part of the left system was, so he was taken to the cath lab after loaded with ticagrelor because of the active chest pain, aspirin, heparin, and then was taken to the cath lab. The left system did not demonstrate apparently any significant stenosis apart from ISR to a circ and LAD, but was non-significant. So this is what I like to share with you, is the right system based on the EKG changes and the minimal leak of his troponin. I apologize. Okay, as you can see, okay, he had a previous stent in the probably ostial and the proximal side of the RCA, but you can appreciate that the patient had probably a ruptured plaque at the distal end of the vessel. So I hope that's clear. So I'm going to run it again. As you see here, I thought that this is probably a ruptured plaque at the distal end of a dominant RCA. And apparently he had a middle lesion here and stent restenosis. So I elected to proceed with wiring of that RCA and to fix probably the rupture plaque at the distal RCA. So as you see here, I have a stent placed distally, direct stenting, and this is the result of the distal RCA that was stented. And then I tried to look at that in-stent restenosis and the lesion distal to the stent that placed 3 years back. And I elected to proceed fixing that in-stent restenosis for that RCA. Start ballooning pre-dilatation to prep the lesion. So this is after, this is post-dilatation. And then I decided to place a stent. I was trying to find a spot to place the stent properly. Do you see anything abnormal in the last movie? So at this point, I knew that I'm running into a trouble. Please try to focus on the running film. So apparently, I had a complete strut fracture of the stent that I placed just in the old stent. I measured it was 4.0 by 18, and the strut that slipped actually, and the total fracture of the stent was 10 millimeters. So 8 millimeters of the placed stent was on place, and the remaining part that completely fractured, unfortunately, slipped distally.
Can you play it again, please? Because we don't get this point. Is fracture or just cramp inside?
Because, well, to be honest with you, I measured it carefully in my cath lab. At that point, it was 18 millimeter stent length, and all what I have that slipped distally was 10 millimeters.
So it's
accordion.
It's just a...
It did not recoil, to be honest with you, because I found, I will show you in the stent boost, that I have a part proximal remained distal to the lesion that I tried to fix initially. So I will show you in the stent boost.
It is not longitudinal deformation, maybe it's a longitudinal deformation of the stent.
So what he's saying is that if it was accordion or longitudinal deformation, you wouldn't be, he's going to show us on the stent boost.
So I'll show you on the stent boost that I have this completely fractured
ليه ما
stent.
بتحطوا لنا الميكروفون؟ يعني بدنا نحذر كل مرة؟ خليه on خلصنا بقى.
سامعين انتم؟
طيب. It's on. Anyway, what
So I'll
he's
move
saying,
forward for the sake of time, and then...
Yeah, we're going to give you 2 extra minutes, but you are going to convince us that part of the stent
Absolutely.
I mean, part of the stent was cut and is lodged proximally, and another part is lodged distally.
Absolutely. And you can compare the first images that I start placing my stent and compare it to the subsequent images that will show that this is a complete fracture of the stent. So I tried actually ballooning that recoiled stent or part of the stent that migrated distally, and with the help of actually body wire and I tried several times to introduce another stent to fix this fractured stent. Unfortunately, I had to change my guiding catheter, and I had, for an extra support, and I had to keep ballooning through this fractured and recoiled part of that stent that migrated distally. And with the help of a microcatheter and another wire, I was able. Here is just to show you that with the stent boost that I had partially part of the stent was placed proximally and part of it was fractured and displaced distally.
I'm not sure it's very convincing, honestly. I mean, show us proximally where you think the first part of the cut stent.
This is the cutoff of the previous stent, and this is my stent that I just placed. It's
hard to really, I mean, without an IVUS, I think stent boost is not.
Well, I agree with you. I didn't have an IVUS, but with measurement of the struts of the stent.
18 millimeter stent cannot be crushed in two parts. You will see a very small part of 2 millimeter or 3 millimeter above, and the other is down.
Well, I had like 8 millimeters already placed underneath the previous stent, and that was measured clearly in the cath lab.
Go back.
How is cutting? How is broke?
How is that?
How it's
proved?
Happened? No. I'm believing you, but I would like to think how this stent fracture inside the coronary.
How did it cut? I mean,
I
wouldn't even call it.
Well, there is definitely in the literature. Let me finish, Ra'id. I had definitely in the literature a lot of cases that published with a complete strut fracture, and it proves actually in certain situations.
But after the procedure, when we have a procedure done, maybe the tortuous artery, the stent fracture, and this has been reported with the old generation of the drug-eluting stent like Cypher 1. Well, but with this one...
Well, even with the sirolimus eluting stents, we have documented in the literature.
Go back to the stent boost.
Not on site, when you do the procedure. The stent broken inside.
Go back to the stent boost if you don't mind.
Okay.
Because I think if it was a cut stent, I'm not going to call it fractured because it's like cut in the middle or something.
This is
you would see that part very distorted if it was really cut. Yeah. But you see here as a very beveled, it's really very straight, it's not distorted. You see the strut cells very nicely. It doesn't look like a cut stent, but the one below looks like an accordion stent.
Well, the geometry definitely here in the stent boost clearly showed that the geometry is different.
Yeah, but the distal end of it is very neat and clean.
I'm talking about the proximal of a fractured one.
The proximal of the distal?
Exactly.
The proximal of the distal, yes. This is what I would expect to see up there too.
This is what I'm telling you. So the geometry is definitely abnormal of the distal fractured one.
Okay. So go ahead. We'll let you finish the.
Yeah, it's very nice. You know, it's.
Go ahead.
It's okay. Go ahead.
All right.
If you have an OCT, it will be fantastic.
Of course.
Yeah.
So we kept actually ballooning, trying to open this strut in order to cover this part that shown actually. And you can see here, apparently, this is what I'm telling you. The nature of the vessel, the native RCA, was definitely distorted actually after having the stent. This image was not there before placing this stent and migration and the fracture of that distal part. Anyway, I was able, luckily, let me here, please. To balloon and to stent with a long one. I changed the type of the stent that I placed initially. This is the final result, and as you see, that part that covered with the stent totally improved compared to the previous images that I showed you a minute ago. So this is my final result that I thought that is acceptable. And I will give a few slides here about coronary stent fracture, which is defined as discontinuation of any part of the stent structure seen in the angiogram. Stent fracture was first described with bare metal stent in 2002. In 2004, it was subsequently reported with drug-eluting stent, typically, as you mentioned, in the Cypher 1, but apparently with high prevalence more in the sirolimus-eluting stents, more it was actually reported in many literature review. The newer designs, materials, and eluting drugs are being developed to improve the performance, safety, and long-term patency of these drug-eluting stents. Coronary stent fracture is thought to be due to a combination of unfortunate factors. These factors are all related to abnormal forces placed on the stent, creating metal fatigue and eventual fracture, vessel tortuosity, as you said, mainly in the right coronary artery, vessel calcification, ostial stent location, hinge motion, overlapping stents. This is what I had, and increased stent length, probably balloon overdilatation that I had to prep my lesion several times. That what might exhaust my stent and probably causing this axial stiffness and causing that to be fractured. So overlapping stents, by enhancing axial stiffness, possibly increases the risk of stent fractures. A clinically concerning complication, definitely acute coronary syndrome, if you leave it alone, and stent restenosis, stent thrombosis, and possibly the need for target vessel revascularization. These manifestations are related to the disruption of the stent structure and the malapposition of the stent struts to the intimal surface. Normally, a drug-eluting stent will provide sufficient amount of anti-proliferative drugs in the vicinity of smooth muscle cells and the vessel intima. However, during strut fracture, the struts are usually elute. The drugs are no longer adequately pressed against the vessel wall. This allows smooth muscle cells to proliferate, and the fracture strut can also mechanically irritate the vessel wall and stimulate smooth muscle cell division, as well as to become a foci for thrombogenesis. This can lead to, unfortunately, a cascade of events that end up with hemodynamic problems and complications. These are kind of types of stent fractures. Type 1A stent fracture with a single strut fracture, type 1B with a gap between the two struts, and the type 2 incomplete or transverse with a V gap, and type 3 that you might face a complete transverse non-displacement, with a type 4 with a complete transverse and displacement of the stent. So the algorithm to treat, if the patient had no complete fracture, then you go with medical, probably antiplatelet. If your patient is not actually having a significant restenosis rate, and probably you need, as you said, and those patients that you will leave them for medical treatment, probably you need an IVUS or a stress test. In our case, for me, this is a typical strut fracture that mandating actually to complete the job and not to leave it for medical therapy. So I have to fix the whole artery, and that was it. Thank you.
Thank you very much, Dr. Islam Abu Sido. I will invite the last speaker of this conference, Dr. Aram Jamal Mirza from Iraq, who's going to be talking about intravascular lithotripsy in left main disease.
Ladies and gentlemen, dear all my colleagues and friends, dear Mr. Chairman, good evening. It's actually a great pleasure for me to be with you today. And I would like to thank the organizing committee, mainly Dr. Mahmoud, for inviting us to be with you in this elegant conference. I know the time is not so good to have a presentation, but I will try to be so fast to run within the time. My presentation is about using debulking device, mainly IVL, in an elderly lady. However, a lot of slides have been covered by Dr. Balbaz before this presentation. All the presentation is about the case who is 82 years old lady. She is an overweight lady. This lady had a history of ischemic heart disease 8 years ago when she developed anterior SMI, and she underwent intervention at that time for LAD and LCX. She was doing well till the last 6 months when she developed recurrent attack of chest pain and pulmonary edema. All the time she had been admitted to the CCU for the sake of chest pain or pulmonary edema. And she doesn't have any risk factor apart mainly diabetes. She's not diabetic and not hypertensive apart from dyslipidemia. And in the last 5 years, she developed end-stage renal disease. She was on regular hemodialysis. She was typical angina, class 3 to 4 angina, and the ECG doesn't have any significant change, and her thoracic echocardiography show fair LV function with mild to moderate mitral regurgitation. All blood tests were good apart from anemia from his chronic renal failure. And this is the baseline angiography. I don't know whether the slide is working or not. I'm afraid because the system, can you have, please, can you, please? Okay, okay. We have some problem because the system I have prepared my slide is not suitable with this computer. All right, okay, this one. No, this one, please. This is the baseline angiography. If we have a look on the angio, we have got tight critical distal left main lesion is in a heavy calcified area, followed by a patent stent. However, there is a focal ISR in the previously implanted stent 8 years ago. We have got a patent stent in the mid-LCX. And if you have a look to the photo on the left side, we can appreciate how the amount of the calcium in the proximal part of the LAD. This is another view. We can see that the mid-LAD is also diseased. The L6 is not so bad. However, the ostium of the L6 is diseased. And this in the spider view. We can see that how the left meniscus is tight. So for these cases, when the patient have been sent for the surgeon, but the surgeon have refused, declined the surgery for this lady as she's 82 years, and the family and the patient already they declined the surgery. So at that time we decided to do blind PCI for this lady. The plan was to do the debulking for this left meniscus because, as we mentioned and from previous presentation, for this calcified lesion, if you are not going to do debulking or to make a crack in the left meniscus, definitely the procedure will be end with some of the under expansion and the rate of the MACE, which will be too high in the future. So we decided to do lithotripsy instead of rotablator because if you have a look on the previous angio, in the main in the spider view, we can find that the proximal LAD, we have a stent there. So it's very difficult to do rotablation for that area because we may touch or may hit the proximal part of the previously implanted stent. So for the IVL, a lot of tricks have been discussed with Dr. Belbaz before, but one of the important ticks and trip in doing IVL is that the size of the balloon should be 1:1 to the size of the reference diameter of the vessel. It's not like the rotablator. For rotational atherectomy, we are using 0.5 to 0.6 to 1, the ratio of the bird to the main vessel. While for the IVL, the size should be 1:1. That's why it's better to have IVAs before every procedure of the IVL. So just why the IVAs, we have found that the size of the left meniscus is only 3.4. That's why we have to choose the size 3.5 IVL. This is the IVL. This is the beauty of this device is it not need a special training. It's just crossing the floppy wire, making the balloon dilatation. Only one obstacle is that when you have got severe calcification, you cannot cross the balloon. At that time, you should do rotablation and to do IVL. This is rotatripsy. It's mentioned to be rotatripsy combined both procedure. So during the inflation of the balloon, because you can have a right to do 10 shocks. With each inflation, you can have 10 shock. Each shock is about 10 seconds. So during inflation, because we were occluding the left main stem, unfortunately the patient became collapsed and she developed recurrent attack of VFib, and all the time she was resuscitated. And to be honest with you, this procedure should be done with the assist device. Unfortunately, still in Iraq and Kurdistan, we doesn't have Ampella. Another time, the size of it doesn't available at that time to have a support device. So during the procedure, the patient developed ventricular fibrillation, VFib, and she resuscitated. And after that, the procedure went smoothly when we did implantation of the C5 stent and post-dilatation there. And I don't want to go through the case because Dr. Hadi have talked a lot about the left main stem PCI. So just want to show you this is after doing this, we have the pot with the biggest. After doing pot, we get some jeopardization of the, not pot, after stenting, we have jeopardization of the LCX ostium. However, it's basically disease, but we don't want to put a lot of metal in this elderly lady present with end-stage renal disease. So only after ballooning, we found that the flow in the LCX is very good. And this is the view. After that, we implant another stent with LED because it was diseased, 8-75. I was done, and during I was, we have found that the stent, the left main stem, is not well apposed. It's not well apposed. That's why we took a larger balloon. It's 4.5. Remember that the size of the stent, it was 3.5, and the advantage of this new this new stent is that 3 can be over-expand to 475. And later we did IFAS after this post-dilatation, after this pot. We have some problem in the, because if you have a look on the pulse, it will not be generated all around inside the vessel, so it never make any crack. Well, the next one, because the calcification is concentric, so the pulse will be generated and it will make a crack all circumferentially in the vessel, inside the vessel. So this is the main mechanism of action of the IVL. And the beauty is that not in the training and there is no any complication. It's not like a atherectomy or rotational atherectomy. It doesn't have any complication. And my last slide will be, sorry, to take home message is that all the time plaque modification is very important. Never put a stent in a calcified lesion before good stent lesion preparation, and you have got a large chunk of calcification all the time. Please do debulking. And never leave any left main stem stent without pot. If you have a look on this slide, it's very nice because look before pot, sometimes we are feeling that we have opened the vessel, the stent, and everything is good. But pot, it preventing any the problem or any under-expansion of the stent. And thank you very much for your kind attention. Thank you.
Thank you. Welcome, all of you. Closing remarks, we have Elizabeth, Senior Manager of Sky, please. And we have Dr. Nail Shobaki and Dr. Adnan Khafaji. We'll start with you. Ladies first, right?
Dr. Israk, I just want to tell you how honored Sky is to be a part of this really incredible and important meeting. I want to start by thanking Dr. Israk, who is the president of the ICIG, for initiating this amazing partnership and collaboration. I'd also like to thank Dr. Hatem Al-Badi, who is the president of the Jordan Cardiac Society, Dr. Youssef Goussos, and also, of course, Dr. Firaz Al-Hawari, the Minister of Health. I just am absolutely excited, and the PCI Mena course, if this is the third, it's just been a really seamless production. The science is outstanding, the presentations, the case exchanges, the dialogue, the engagement with the audience. The MENA region, the Middle East, North Africa region, as we know, is seeing, an increase in heart disease. Unfortunately, we're seeing that around the world in countries that hadn't really had a very big problem. But in the last several decades, those numbers have risen. So as part of the cardiology community, as an interventional cardiologist, it's exciting to watch that this region, the countries in the Middle East, the countries in North Africa are rising to this challenge. They're developing their, the procedures, they're sharing the education, and they are some of the best in the world. So I am absolutely thrilled to be part of this. Sky is proud to be a part of PCI Mena. We are looking forward to next year, bigger, better than ever. I hope you all are going to plan on attending. I also want to encourage everyone to look at sky.org, be a part of our community, be a part of the programs that we have. It's free to join, and there are limitless areas to get involved. You can work your way from a fellow all the way to M-Sky. We also have our scientific sessions in May 18th through 21st in lovely Phoenix, Arizona. We're going to be including in the case exchange session a session with the Jordan Cardiac Society and ICIG. So we'll be really excited to bring the physicians in to scientific sessions next year as part of our global case exchange session. So again, I want to congratulate everybody. I want to congratulate Dr. Izrak. Your work has been outstanding. I don't know how you do it. I think you have 28 hours in a day, apparently. But again, I don't want to take up too much time. There are more important speakers, but as a representative of Sky, thank you, and we're honored to be a part of this. Look forward to many more years of friendship. Thank you.
الله يعطيكم العافية. يعني مع نهاية أعمال هذا المؤتمر لا يسعنا إحنا أعضاء اللجنة المنظمة هذا المؤتمر إلا حقيقة نشكر الحضور الكريم على الحضور كل هذا المؤتمر على يومين كاملين. نخص بالذكر طبعا الإخوان الضيوف على بلدنا من جميع الدول العربية الشقيقة والدول الصديقة. نتقدم أيضا بالشكر للأطباء المشاركين على الحالات القيمة التي قدموها، وأخيرا كمان نشكر الشركات الداعمة والراعي لهذا المؤتمر. قبل من كلمة الدكتور عدنان بس نعلن إنه the next MENA conference will be in July next year إن شاء الله. الله يعطيكم ألف عافية.
شكرا جزيلا دكتور نايل. باسمي وباسم الأخوة من أخصائي القلب والتداخل القسطاري نيابة عنهم من كل مراكز القلب في العراق الذين حضروا السنة هذه 22 طبيب من اختصاص أمراض القلب والتداخل القسطاري تشرفوا بالحضور لهذا المؤتمر البديع، المؤتمر العلمي الثالث PCI MENA. أتقدم بالشكر الجزيل للأخوة والأساتذة والأصدقاء في المملكة الأردنية الهاشمية، أخص بالذكر الأستاذ الكبير القدير الأستاذ يوسف القسوس، والأخ الكبير الدكتور محمود الزريق، رئيس مجموعة ICIG. الشكر الجزيل لكل الأصدقاء والأخوان في المملكة الأردنية الهاشمية والأخوة من فلسطين العزيزة ومن مصر ومن لبنان ومن كافة الدول العربية. أتقدم لكم نيابة عن الأخوة العراقيين المشاركين في هذا المؤتمر بالشكر الجزيل وحسن الضيافة والاستقبال، وأتمنى أن يكون المؤتمر في السنة القادمة متميزا وناجحا، وبجهودكم جميعا وخاصة في هذه المنطقة التي يوجد فيها كفاءات علمية متميزة. From Iraq and interventional cardiologist from Iraq sharing in this meeting, I would like to thank a lot the Sky for their support for this conference, and we are ready to collaborate with them and to promote such a distinguished conference. Thank you very much.
دكتور حسام الساد رئيس جمعية أطباء القلب الفلسطينية، تفضل.
مساء الخير جميعا. يعني احنا في نهاية هذا المؤتمر بشرفني كرئيس للجمعية وباسمي وباسم زملائي في فلسطين أني أكون معكم اليوم. على مدى يومين قدمنا حالات مميزة. احنا من 3 سنين أو 3 مؤتمرات كنا مشاركين فعالين في هذا المؤتمر. السنة هاي كنا في حوالي 50 طبيب interventional cardiologist من فلسطين. احنا في فلسطين الحمد لله رب العالمين في خلال السنوات الأخيرة كان هناك تقدم كبير في الانترفنشنال كارديولوجي. احنا عندنا في الضفة الغربية أكثر من 10 سنترز بتشتغل انترفنشن وكارديو سيرجري. بحب أنا أشكر زملائي بداية اللي هم من فلسطين. الوضع في فلسطين وضع مأساوي، وخصوصا في هذه الأيام وضع شبه مستحيل الوصول إلى هون. كان البلان تبعنا إن نطلع بكل سهولة وإشي. كل طبيب خرج من مدينته باليومين اللي فاتوا وصلوا لهون تعنا كثيرا، ويمكن أخذت منه ساعات طويلة، منه أخذ طرق التفافية ووصل للحدود الفلسطينية الأردنية حتى يوصل لهذا المؤتمر بجهد. بعضكم بيستهين في هذه الأمور، ولكن إحنا بالنسبة لنا هاي أمور بالنسبة لنا حياتية. يعني الإنسان بيطلع بالطائرة بيحجز تذكرة أونلاين وبضل طالع بيجي على الأردن بقضي. إحنا بنفكر بس كيف نوصل لهون وكيف نخرج من هون. رغم كل هاي الظروف فلسطين صامدة، فلسطين موجودة على الخارطة، فلسطين رغم أنف الصهاينة وأنف من تصهينوا معها موجودة في هذه الأرض، ورح تكون إن شاء الله حاضرة في كل المؤتمرات ممثلة بأبنائها الأبرار في هذا الوطن. وأحب أشكر كل الأخوة الزملاء اللي أعطونا هذا الفرصة إن نكون دائما معهم. على رأسهم أخونا وحبيبنا الدكتور محمود، أخوتنا العراقيين، أخوتنا في مصر، أخوتنا في الدول العربية الشقيقة كلها. شكرا لكم، وإحنا دائما معكم. نتمنى دائما دعمكم، ونتمنى يكون يوم من الأيام في مؤتمر مثل هذا المؤتمر في القدس الحبيب إن شاء الله. شكرا.
شكرا للجميع. PCI Mena 2023. أهلا وسهلا. And we'll go نأخذ صور جماعية الآن.